Thank you, Ellie, and welcome everyone to our closing plenary. It's hard to imagine where the time went, but here we are. There have been so many great sessions, so much fantastic information, and it's been so enjoyable to be with you virtually. Before we get into the closing session, I just want to also remind everybody of a couple of things. The token hunt game has been very popular. We'll be doing the drawing for up to $250 right after this session. So you do still have a chance to get yourself a couple of tickets, get in that big jar with your raffle tickets. Also, next year, we hope to see you in person with us in Boston. So please make sure that that's on your calendar and put that into your budgets. At this point, I want to introduce our closing plenary session, which is going to be a panel on race and ethnicity, how to supplement data for health equity studies. This session has been organized by Tanya Bernstein from Friedman Healthcare, one of our NATO board members. The moderator will be Jesse Drummond from OnPoint Health Data. OnPoint is one of our featured partners. This session is sponsored by Human Services Research Institute. And now we'd like to hear just a little bit from Leanne Kandura of HSRI.
Good afternoon, and welcome to the closing plenary for NATO's 37th annual conference. I'm Leanne Kandura, Vice President at HSRI, and I direct the work of our population health team. Human Services Research Institute is a proud sponsor of this panel session, Race and Ethnicity, How to Supplement Data for Health Equity Studies. As the saying goes, nothing about us without us, which captures the idea that in the spirit of a thriving democracy, policies need the full and direct participation of members of the group affected by the policy. HSRI, like NATO, is a mission-driven organization where we work to improve systems that improve lives. To successfully fulfill our mission, we actively work in almost every state to assess and report on the health of people in the communities where they live and work, contextualizing and disaggregating data to better identify and understand health risks and outcomes by race, ethnicity, age, disability status, sexual orientation, and gender identity. HSRI's population health team was founded a decade ago when we started to contribute to the goal of providing high-quality data for health systems research. We began our work in partnership with the Maine Health Data Organization by transforming their hospital encounter and all-payer claims databases into the robust, innovative, and enhanced data resources they are today. Since then, our team has been able to partner with states to achieve and consistently deliver high-quality data that is available and accessible for research, policy, and practice, all while pursuing opportunities to integrate and supplement these data to further health equity. We believe that equitable policies underpin healthy, thriving communities, and developing these policies require data to better understand and address the issues that communities should be focusing on. We believe in equity-focused research, data systems, and policy advising. We believe in collaborative, inclusive research where the people and communities affected by an issue share meaningful roles in the effort to devise solutions to improve health and human service systems. I am proud to serve on the NATO board and as a sponsoring organization to continue bringing members and other stakeholders together to share invaluable learning sessions like today's closing plenary. I want to challenge each of us to continue to create opportunities to empower the communities we serve to actively contribute to the conversations and policies informed by their health or healthcare data. Without this engagement, we won't truly understand the impact of our efforts. And without further ado, I'd like to hand over the closing plenary to my fellow board member, Tanya Bernstein with Friedman Healthcare. Thank you.
Thank you, Leanne. At this point, we're going to bring on stage Jesse Drummond, our moderator. Jesse, so I'm going to turn it over to you and let you introduce the panel and get right into it. So we'll see you on the other end.
Wonderful. Thank you, Norm, and thanks to everyone at NATO for putting on this wonderful conference. Good afternoon, everyone, and thanks for joining us. My name is Jesse Drummond, and I'm a health analytics manager at OnPoint Health Data. OnPoint's a nonprofit based in Portland, Maine. We've been building and managing all-payer claims databases, or APCDs, and multi-payer claims databases, or MPCDs, starting with the first MPCD in Maine back in 1995. Today, we'll be talking about the availability of race and ethnicity data in claims databases, and two very exciting efforts in Rhode Island and California to augment or enhance what is currently available. Before I go any further, let me introduce our panel. We have two representatives from the state of Rhode Island. So let's bring on William Hendon. William is a dedicated public health professional with years of experience at the local and state levels of government. He's currently serving the state of Rhode Island as the project manager for Health Facts Rhode Island, a longstanding APCD initiative that produces and maintains public-facing dashboards in an effort to promote the transparency of healthcare provided to Rhode Islanders. Thank you so much for joining us, William.
Happy to be here, Jesse.
All right. Also on the panel is Rebecca LeBeau. Rebecca is the Director of Data and Analytics at the Rhode Island Executive Office of Health and Human Services. In this role, she directs an analytic and technical team that promotes data integration, utilizes state data to inform policy development and program implementation, and also engages in monitoring and oversight activities that vary based on state initiatives. Thank you for joining us today, Rebecca.
Thank you.
All right, also on the panel today are Annalee Amernath from the Integrated Healthcare Association, or IHA, and Mark Elliott from the RAND Corporation. Annalee oversees IHA's Align, Measure, Perform, or AMP, program strategy and execution to effectively create and deliver performance data, aligned incentives, and analytics products to clients and the healthcare industry. She also facilitates IHA's Health Equity Committee, which was developed to identify strategies and opportunities for the organization to support industry-wide improvements in health equity. Thanks for being here today, Annalee.
Thank you for having me.
Absolutely. And Mark Elliott is a senior principal researcher at RAND and holds its distinguished chair in statistics. His areas of interest include health equity, quality measurement, and patient experience. He's developed Bayesian models of estimating or methods of estimating race, ethnicity, and associated disparities using information including name and address. Thanks for being here today, Mark.
Thank you.
So I want to thank our panelists for bringing their expertise to this audience today and for all their efforts to move the industry forward. I'll turn it over to them with a few questions in a moment, but first I'd like to set the stage. Today, most claims databases lack sufficiently complete and accurate data on the race and ethnicity of their members. I'll share some statistics that illustrate this in a moment, but first I'd like to talk about why this is the case. Claims databases largely get race and ethnicity data from the eligibility information that are submitted by health plans. This eligibility information is collected on enrollment forms when members sign up for coverage, and many enrollment forms don't collect race and ethnicity. Conversely, race and ethnicity data are frequently collected by providers, most notably hospitals. In 1997, the Office of Management and Budget mandated that all organizations receiving federal funds must collect race, ethnicity, and language data. However, hospitals don't submit these data elements to health plans. X12 standards, the adopted standards for healthcare information transactions, do not include a place on claim forms for race and ethnicity. So even though hospitals collect these data elements, there's no mechanism for them to flow to plans and from plans to claims data warehouses. And the discrepancy between the two sources is sizable. In 2019, the APCD Council gathered information from 5 state APCDs and from hospital discharge databases. They found that at a statewide level, the proportion of hospital encounters in the discharge data that have a valid non-other race code range from 81% to 99%. On the other hand, in the 5 state APCDs, they found that the proportion of records with a valid non-other race code ranged from 13 to 44%. So in the hospital discharge data, it's 81 to 99%. In the APCDs, it was 13 to 44%. And for ethnicity, the proportions were even lower, ranging from 0, one state didn't collect it officially at all, to 35%. And it's important to note here that all of those APCD data included Medicaid records. And we know that Medicaid does a better job of collecting these data elements than other payers. So these figures highlight the challenges that users of claims data face. And these challenges limit the ability of health plans, delivery systems, researchers, and policymakers to analyze patterns in utilization, quality, and value across racial and ethnic groups, identify disparities in care, and design targeted interventions to improve the healthcare delivery system and more adequately serve communities that are historically overlooked, underserved, and under-resourced. That brings us to our panel discussion today. I'll pose a few questions for the panelists, and we'll discuss some of their initiatives to address those challenges I just described, and then we'll have some time at the end for questions. So, without further ado, William, I'd like to start with you. Can you please tell us about the Current Care program and how it was designed, and how it can be used to augment the self-reported race and ethnicity data in the Rhode Island APCD?
Yeah, of course. Great question. So how was the program modeled and designed? So Rhode Island's approach to improving our APCD's existing race and ethnicity data that we get from the member file was actually guided by a 2020 decision that directed the state to only collect race and ethnicity data from self-reported sources and not to impute any of those data points or either of them. This instruction really required the state to research and engage stakeholders who were already involved in the collection and aggregation of those fields of data. For Rhode Island, the path of least resistance meant directing our focus to the state's health information exchange, Current Care. Health information exchanges mobilize healthcare information electronically across organizations, be it within a region, community, or hospital system. Current Care gathers information from labs, imaging centers, pharmacies, public health data, specialists, hospitals, et cetera, and primary care. So it's a pretty robust source of data that we were looking into. And luckily, we found that more than half of all Rhode Islanders have enrolled in Current Care, along with hundreds of primary care and specialty practices, community health centers, hospitals, long-term care facilities, et cetera. So it's a very big program that is, has high levels of participation rates. So through extensive collaboration, leveraging endorsements from our director of health, and executing the necessary data sharing agreements and things like that with our state's health information exchange, Current Care, we were able to start receiving all of the available self-reported race and ethnicity data Current Care could offer. So Rhode Island is a state, a little bit of context, Rhode Island is a state that takes residents' data security and privacy very seriously, and by law is required to utilize a vendor to provide data de-identification services for the APCD. And what this means is that in order to link the identifiable Current Care race and ethnicity data file to the de-identified data in our APCD, we needed to have the race and ethnicity file follow a similar submission process as all of our other data submissions from the traditional commercial payers, which essentially the process is that a member file is first provided to our lockbox vendor by data submitters, and our lockbox vendor references the master patient index that they keep for Rhode Island, and a unique member ID is then appended at the individual level, and the file is sort of sent back to the submitter. So de-identified eligibility, claims data, and other files, including those unique member IDs, are then transmitted to our data management vendor and then ultimately to the state data center. So this process, this whole de-identification process and assigning those UMIDs from our master patient index allowed us to link the race and ethnicity data provided by Current Care with the data already housed in the APCD, since our vendor assigns those UMIDs to the data.
Got it. Yes, thank you. Thank you, William. So with this programming in Current Care, you can append race and ethnicity values for many of the state residents, right? Can you say again what proportion of residents are part of Current Care?
Yeah, of course. So a little over half of Rhode Islanders have signed up for Current Care. And I can go into the limitations and benefits of our approach if that's more of what you're after.
Sure, please. Yeah, I was going to highlight that as one of the strengths, but because that seems like that's a lot of people, which is wonderful.
Yeah, of course. Oh, there's always some more context. So one benefit of our approach is that we do now receive a file quarterly with race and ethnicity values for over 35% of the members in our APCD, whereas the typical APCD may have anywhere from 1% to 3% of its members both race and ethnicity data fields complete. So once agreements were put into place with Current Care and the state, there was a pretty quick adoption, and the use of those existing lockbox de-identification processes that I was talking about really streamlined receiving that data. So that was a big bonus for us. We seem to have the structure and systems in place to, adapt and change and bring on this new data. So utilizing this data, this new race and ethnicity data, actually increases our ability to evaluate the effectiveness of intervention programs aimed at improving patient outcomes. We can dive a little bit deeper and identify the populations that you were talking about, the marginalized, under-resourced populations. And so those are some of the benefits. There's limitations with everything, of course. So the limitations of this approach are that we only receive what's available, in that we're limited to the data collected by the HIE Current Care. Since its inception, Current Care has operated under an opt-in model, so an opt-in consent model. This means that individuals need to sign up for Current Care to benefit from the system, and also that means they have to sign up for us to get their data. However, in July of 2021, so last year, the consent model for the HIE was approved by Rhode Island State General Assembly and the governor's office and everyone who had to sign off on it to transition Current Care into an opt-out model. So this is going to be beneficial to all of the patients of Rhode Island, the medical community, and also the APCD, as availability and collection of much more data is expected. However, we're not expecting more robust race and ethnicity data from Current Care until at least 2024, given their current implementation timeline. And I think we're going to talk a little bit later about how Rhode Island plans to improve their race and ethnicity data over the next 2 years before Current Care's switch to opt-out. So stay tuned for that if you're waiting on that information. Lastly, like with all emerging attempts at gathering and aggregating data, the obstacle of standardization is present. And collection of race and ethnicity is no exception. There isn't necessarily a lack of standardization of the race and ethnicity data we receive from Current Care. It's actually a pretty good source of race and ethnicity data. One thing that works in their favor is the data that gets submitted to them goes through a standard data feed protocol called Health Level 7. Essentially, it standardizes a lot of the fields and data. So providers may already be standardizing on what HL7 expects, removing a lot of that non-standardization and the need for a cleanup. Lastly, I'll say any lack of standardization is general in this area is generally across systems, and that would definitely be one of the definitely be one of the limitations of collecting this type of data. So that is to say, the Department of Human Services doesn't collect it in the same way as Current Care, for example, which doesn't collect it in the same way as Department of Labor and Training. Different state agencies collect it different ways, and there are a number of discrepancies. And I'll close with a few of those discrepancies being, some agencies combine ethnicity and race together, some don't. Some only allow you to choose one race, others allow you to choose multiple. Some allow you to specify multiracial, and others you can sort of infer it if they have multiple selections. Whereas others, it's sort of not possible to capture that multiracial aspect. And then lastly, some break out Pacific Islander from Asian, and some do not. So I would say that's just something that comes with the territory of looking at this data.
Got it. Yes, thank you, William. We'll definitely get into some of the next steps for Current Care. I'm excited to hear more about that. Before that, though, I'd like to pivot and hear about a complementary method that IHA is exploring. So, Mark, can you please?
So
yeah, go ahead.
I'm gonna talk more broadly about sort of the family of work that IHA has implemented. And I'll start by talking a little bit about the sort of background that led us to start working in this area. So when we started working on indirect ways of estimating race ethnicity for the purpose of measuring health inequities where complete and self-reported race ethnicity wasn't available. Very little good racial ethnic data was out there, and health plans who had once hesitated to ask information that people might have suspected was going to be misused now actively wanted that information for pro-social uses. And a lot of as you've noted, a lot of that information has accumulated slowly. I should start by saying that that the Rhode Island initiative sounds fantastic to me, and the gold standard self-report is always the way to go for all of these purposes, and wherever it exists, that's certainly what we support, and I think innovative ways of standardizing and collecting that are key. One of the challenges that we faced is that a lot of is sometimes confusion about what gold standard self-report is. A lot of times medical records that are based on third-party appearance-based observation are treated as being self-reported, and that's obviously not anything anybody would want to see happen. In other cases, you have and I guess this falls under the standardization category. You have older forms that don't allow people to use the racial and ethnic responses that they want to use, and so you have things that you need to do to try to better align with what people would respond if they could. And a lot of times we deal with incomplete and unrepresentative data. So in some work that's recently described in JAMA Open that we've been doing with ASPE and in the marketplace setting, they've collected data on 70% of their marketplace enrollees, which is terrific. But it turns out that because the way that data comes in, it's really unrepresentative in terms of race and ethnicity, and also in terms of other aspects of people's experiences. And so when we were able to do what we recommend, which was to make estimates based on self-report where it's available, supplemented by group level imputations where it's not, they were able to see ways in which their self-report alone really didn't accurately reflect enrollment or enrollment experiences. So with that bit of background, our basic approach has been to use commonly available information, often name and address information, geocoded and linked to census products. In some cases, we've done more specialized things, like for CMS Office of Minority Health work for Medicare beneficiaries. But in all these cases, what we're essentially doing is trying to generate a probability associated with each person that if they were given a standard self-report form, they would select that group. And we recommend that we use probabilities in part to recognize the uncertainty involved in any individual case, and also to recognize and remind people that we're not making decisions about individual people based on information they didn't directly supply. But these can be combined in ways that allow us to make accurate inferences about groups. So I could stop there. I forget what our timing is, or I could say more at this point or later.
I think a bit more background right now in terms of benefits, limitations, things like that would be wonderful, and then we can go to sort of how these different methods are being applied.
Sure. So a little bit more. So I think that the benefits are that where there are low levels or unrepresentative participation in self-reported race ethnicity, this allows you to fill in the gaps. There have been we've helped CMS's Office of Minority Health produce reports that have identified health inequities that wouldn't have been possible to understand otherwise. A number of health plans that have been early adopters of this have used this to improve their health equity as well as overall performance, including the Kaiser system, for example. Some of the there certainly are limitations. One of the limitations is generally the approach doesn't do as well with multiracial. I should also, I guess, still in the benefits category, The level of accuracy for these methods is quite high by conventional standards for prediction. The most basic models for the 4 largest racial and ethnic groups have concordance in the 93 to 97% range. The more sophisticated models, kind of more like 97 to 99.5% concordance for the 4 largest groups. So that would be Asian American, Native Hawaiian Pacific Islander, Black, Hispanic, White. Performance, and sort of segueing into limitations, performance is not as good for American Indian, Alaska Native people for the simpler models, although it's getting better for the more for the richer models. And in no cases is it where we'd like it to be for multiracial identity, which is obviously really important. So that's a limitation. Another limitation is that right now we're constrained to doing all this in the forms that the Census Bureau supplies their data products. We have some requests out with them that we hope to allow us to be more granular in the future and to intersect different categories. So that this is sort of a watch this space kind of situation. But for now, our ability to do this is limited, to those 4 largest groups in ways that are defined in those ways. The use of these data together requires some sophistication and is more analytically complex than when you have complete self-reported data, and so that's certainly another sort of limitation and sometimes barrier. We think it's one that can generally be overcome, but it's certainly the place where we'd all like to be is the point where we have high levels of high and representative levels of self-reported data. So that's the ultimate goal.
Got it. Yes, thank you, Mark. Thanks for providing that background. I'd love to get into how these approaches are being applied. So let's go back to Rhode Island. Rebecca, can you please talk about how you're currently using, are planning to use, or may consider using the race and ethnicity data provided by Current Care?
Sure, and we are using it. It's in early stages, but we've really it's been really exciting for the state to use it. So it's been a priority to integrate race and ethnicity data into any analysis conducted with the APCD data, including so that we can look at addressing disparities across our state, right? What everybody wants to do. So as more data becomes available, Rhode Island intends to add race and ethnicity stratifications to our public-facing dashboards, as well as our general projects that are coming through the system. So the state and researchers perform impact analyses comparing services rendered across payers. And this is stratified by race and ethnicity. And we're looking at things like ongoing opioid developments, tracking quality measures for our Medicaid partners, looking at integration across some of our other state agencies and ways that we can pull in race and ethnicity to further delve into the data in a very specific way. So while Rhode Island is aiming to better address the socioeconomic and environmental determinants of health that we talk about all the time, this is a really important way to do that, to bring in this data and to get better data that we can use. It helps us to identify healthcare needs with much more specificity than we've been able to do in the past. It helps us to think about ways to eliminate health disparities and promote health equity. And we're constantly thinking about how to do that and how to use this data to promote that work. It also helps us to gain increased visibility of the state's vulnerable populations to ensure that we have quality health services and comprehensive race and ethnicity data-supported analytics at all times, regardless of what the question is. Really starting to pull that into all of our thinking going forward when we are pulling analytics from the APCD and other data sets.
Yes, got it. Thank you. Let's go over to California and hear about some things that IHA are doing or planning to do in the future. Annalee.
Hi, everyone. Thank you. So Integrated Healthcare Association's voluntary multi-payer claims database links claims data from our participating health plans to member eligibility data for our Align, Measure, Perform program, as well as our cost and quality atlas for reporting purposes. This is work that we do with our partner OnPoint. And our atlas provides information on over a dozen standardized measures: clinical quality, total cost of care, utilization, for nearly 20 million Californians. That includes people covered under commercial HMO, PPO, ACO, and Medicare Advantage. So we definitely have a wide view of what may be happening within the industry within California. But by looking at our data, we were better able to understand what was happening with some of the direct data collection and reporting of race and ethnicity information, working with our partner OnPoint and utilizing imputation methodologies from our partners at RAND. We were looking at our 2020 data, that would be measurement year 2019, where we had received, IHA and OnPoint had received over 200 million claims from our 14 participating health plans, providing member level data. And linking those claims with member eligibility files, we saw numbers pretty consistent with what Jesse shared with you earlier. About 36% of the data was populated with members' primary race, about 7% was populated with ethnicity. And when you dove in deeper to the actual data from each of our participating plans, the range was anywhere from 0 to 100%. Many inconsistencies in how the race and ethnicity data was populated across the different health plans, sometimes even within the health plan. So similar to what you heard William speaking about earlier, lack of standardization, challenges in collecting this nuanced information in a standardized way. So really not surprising results, low and inconsistent capture of race and ethnicity data through the claims that were available to us for a large portion of California's population. So I absolutely agree with what you've heard from all of the fellow panelists here, just really the emphasis and importance on improving collection, particularly of self-reported data, true self-reported data for use. And there already are a number of efforts underway in California to move forward on improving the collection of direct self-reported data in a more accurate way. But while that's underway, IHA wanted to test the benefit of applying imputation methodologies to impute the missing race and ethnicity data into our system so that it could be used for purposes of looking at groups and populations, perhaps generating information and insights for the industry and for our participants. Our goal was to see if we could improve the completeness of our claims data to understand and look at patterns, racial and ethnic patterns of health disparities regionally in our AMP and ATLAS program. So working with OnPoint and RAND, we did conduct a proof of concept using a subset of our data, about 5 million members, to generate an estimated race and ethnicity, and was able to do so for 98% of the members using the surname and zip code you heard Mark speaking about earlier. So from this, what we could see is that combining what we receive from our participants for direct race and ethnicity data collection with an imputation methodology, there is potential to definitely expand and improve on the data set that we had available to us for purposes of looking at performance on cost, quality, access metrics at a population level. But again, within limitations that you did hear Mark describe earlier. So from there, some of what we've been doing is talking within our health equity committee, within our organization, about what some of the priorities should be for how we could move forward with this knowledge. As I mentioned, with this committee, we are a voluntary all-payer claims database, if you will. We are not a state regulator, so we really do govern our programs in line with what our participants are looking for us to achieve. Our committee is absolutely interested in continuing to look at what we can do when it comes to imputation, how that can be either validated. We can do further validation studies against self-collected direct reported data or other data that could be brought into our system, other external data sources that might become available to us. But it was also very supportive of other steps that we're taking within our program to use the data that we do have, as incomplete as it was, as I told you, to begin to report on stratifications by race and ethnicity for those standardized measures that I mentioned earlier around cost and quality, access and utilization. So we will begin to be reporting using that information, hopefully to drive improvements in the collection and accuracy and completion of that information for purposes of the performance reporting. But additionally, one of the things our programs does offer is a voluntary incentive design to our health plan participants and provider organizations. What's really nice is that by aligning the industry around common measures, we're also able to align the industry around common strategic direction and are able to direct those incentives in that way. And we have a unique opportunity compared to some of our regulator partners in the state, where regulators often have sticks at their disposal. They can set requirements for those that they regulate. As a voluntary program, we have the opportunity to be a little bit more of the carrot to try to drive the industry forward. Where do we want to go next? Kind of raise the bar that people can reach for. And so one of the interesting conversations that we're having right now within our committee structure is how we want to think about application of this information, how we want to look at disparities and equity as we consider applying that in a value-based payment model and incentive structure. So really excited about some of the opportunities there, wanting though to move with caution, because we also recognize potential unintended consequences as you start to begin to talk about ways that you can leverage incentives and dollars for rewarding improvements, for rewarding quality and equity when it comes to care. There can be potential consequences for certain providers, certain areas, certain populations they may serve, where we don't want to disincentivize the way that our community is being served. So I don't know if that's a good summary of what we've been doing, but I'll turn it back to Jesse for further questions.
Yeah, that's great. Thank you, Annalee. And that's a really nice transition to kind of where I think we want to go next. So I'd like to have just open it up and have a broader conversation with the panel. You all have just described these efforts that can improve or enhance available claims data. What do you all think are some important next steps to continue increasing our ability to include race and ethnicity in claims data analyses? And I'll just open it up to anybody.
I can jump in if that's okay. I think one of the things that we're trying to do in Rhode Island, and we've really been focusing on this for the last few years, but the focus is getting deeper and deeper, right? We want to really make sure we do work on this, is fostering and strengthening the connections that we have among our state agencies, so that we can start to build on some of that standardization, being able to speak to each other across agencies within our agencies first, sort of really build that foundation inward. So as we're pulling the data in that we're able to also access from outside partners, it's a little bit easier to pull that data together. And so what we currently have is what is called an ecosystem that allows us to pull these data together from our sister agencies, and allows us to look at people at an individual and family level, but without any identifying information, meaning we don't know who the person is, right? So we know some identifiers, that's what we're trying to get at, but we don't know who the person is. And so we're hopeful that building on these relationships and working with our sister agencies, that is one way that together we can access better state race and ethnicity data to pull into the ecosystem and share across all of the analytics that we do in that system. Feel free to add to that, William. I know you're well versed in this as well.
I will say, enabling and fostering those relationships, like Rebecca was talking about. Sometimes agencies will collect data and they don't really use it for anything, or they've got, they'll collect 100 fields and they're really only using 2 of them, and so the other 98 just get collected and nobody's really looking at them or also looking to improve them. So as we start to collect more data from different state agencies, we're seeing the differences in how the data is collected and stored and organized and standardized or non-standardized in some cases. So we're able to communicate back with those state agencies and our sister agencies for EOHHS and say, hey, we can use this data better, and let's talk about how we improve our collection systems and things like that. So Rhode Island specifically, I mentioned before that the current care, the state's health information exchange, is moving towards that opt-out model, but we wanting to get better every month and every year, so we can provide better to the state data to the state and improve health outcomes and things like that. So among these data sets in our ecosystem, as Rebecca was talking about, it's a file that also collects race and ethnicity data from COVID test data that gets reported to the state. So as we move into next year, 2023, we're planning to formally request that that submission file to follow our lockbox process that I was mentioning before. That'll allow us to take this identifiable COVID data that includes race and ethnicity data and sort of mesh that into our existing APCD file, get a unique member ID assigned, and then we, hopefully that increases the robustness of our race and ethnicity data.
I just had a quick comment, and I feel like I'm mainly echoing things that have been said already. But I see standardization as a really key issue to expanding the reach of these efforts and developing consensus about the form in which the data should be collected. And then, from my perspective, opportunities to elicit this information, where those don't exist, I think are a key area. And one of the major data sources that we use for validation for Medicare beneficiaries, we find that on the order of 96% of the people we ask for this information are willing to self-report it. But so really there the barrier is the opportunity to elicit it.
Got it. Yeah, thank you. I want to unpack this issue of standardization because it's come up a number of times. So what is I guess, I know CMS has some standards for collection of race and ethnicity, but what would this group see as good standards to use moving forward, or how do we identify what those are and then implement those? What's the right path to get to standardization?
Well, I think one of the critical factors as you're thinking about getting towards standardization is making sure that you're collaborating kind of across all lines of the industry, all levels within the industry, and ensuring that we're collaborating within our communities as well. Really making sure that all the right people are having the right conversations, coming together, not making decisions inappropriately that they don't understand the implications of. One of the things that we try to do in the work that we're doing at IHA is try to facilitate those conversations and discussions, at least between our health plans and provider organizations in particular. But I really do think an important next step is to make sure we go a step further than that. We're talking with our health plans, our provider organizations, but we really need to be ensuring that we're thinking about the communities and including the communities that we're talking about, and we have these conversations. Within California, there are different entities that may be involved, that may have different relationships within the state. And so making sure that those entities are coming together as well is very important. But really, as you're thinking about standardizing, another critical factor is standardizing information so that it can be utilized together, combined, and looked at in different ways. One of the things we learned through some of our work was that the way our data infrastructure was established both allowed us to do some of this work, but also has some limitations. And one of the things we're looking at doing in our strategic processes going forward is looking at how we can better expand and enhance our data infrastructure to be able to take in additional sources of information that may be outside of what we normally get through our program purposes, how we can utilize that information and link that with the data that we do have for analytics and insights that could be much broader than our current program purposes, so that whether it be for purposes of research or informing the industry within within what's allowable given the data that we have that people trust us with. And so I think some of it is both, one, making sure we're having those conversations around standardization, but then making sure we set up the infrastructures to use that data. Because as everyone said here already, it's only going to get better if we really start using it. And so that's really the steps that you're seeing happening now all around us, is everyone's starting to use this information. People are starting to pay more attention to this information for that reason.
This is a small pivot, but I'll mention it because I think it's related. One of the areas that I work in is the collection and analysis of self-reported data on sexual orientation and gender identity. And one of the ways that I think that that's instructive for other social determinants of health is that there are these twin issues that arise there. One of collecting information in a way that will be usable over time as as terminologies and preferred usage changes, so that you can maintain an ability to trend. And another is sort of recognizing sort of age and generational and other differences in familiarity and usage. In that field, for example, terms that were really on point for some respondents were confusing and misunderstood by others. And so, I think in a lot of ways I'm echoing what's said before, in that it's really important to interact with the people from whom you're gathering information, and a wide variety of them, in order to measure this information in a way that allows people to respond as they intend, and that you as the user of the data understand.
Yeah, I think that's a very important point. Also highlights some of the unintended consequences that Annalee mentioned earlier. I'm wondering if anyone else wants to chime in on standardization or on those unintended consequences, what they might be, and how we can avoid those.
The only thing that I would add is just sort of to echo the importance of talking to the community, talking to not just the community of folks who you're working with within the state, within your counties, but the people in the communities. I think what I've heard a lot is that people aren't even comfortable with the current state of categories that we have for selection. And so they feel like they're putting themselves into a place that they're just not comfortable selecting. So we have a long way to go in getting this standardization in a place where we have many more people comfortable with being able to answer this. I think we also need to, so that's one big piece. It's taken us a long time to get here, and understanding the importance of that for folks who are answering this question is critical. We can't kind of continue to compartmentalize everything into 3 to 5 things to make it easy for us, right? We need to expand that. And then beyond that, we need to be more willing to review this kind of data collection more regularly. I mean, how long has it been since we've made a big leap and said, okay, it is time to change this. It's just not working. We need to open up the doors here and really get at what we need. And these categories need to be representative of where you are. If we're not covering the people of Rhode Island when we're asking these questions, then we're doing the people of Rhode Island a disservice. So it's a combination of both of those things. It's really getting in and asking the question in a way that is way more inclusive than it has been in the past, and then also being more willing to change it as we go forward as needed, instead of just waiting until it's kind of bottlenecked to a point where we're years behind again. So we just need to be more proactive in years to come.
Absolutely. Thank you. I want to open up for questions for the audience in just a moment, but before that, I want to give the panelists, anyone else, another chance to chime in on next steps, if there's anything, any final words folks want to say there.
I just wanted to echo something I heard Rebecca saying, which I think with standardization, there is the potential risks of losing some of the complexity or some of the nuance of the information that can be really valuable. We are lucky in California to live in such a diverse state, and there are times when the way the data is collected, we miss some really key insights potentially as you begin to think about what is being aggregated under these umbrella categories. And there have been times and opportunities in my past work where we've been able to look at that and really disaggregate that and get down deeper into more detailed levels of information than what's typically categorized in those larger buckets. And it can be really fascinating to really see where fascinating and disappointing, I guess, when you see where disparities are hidden because they get covered up once they're aggregating this larger group that doesn't match and doesn't fit with that community that is that you're looking at in that more detailed level. So I just really want to echo what Rebecca's saying. I really do know that there is a need to find standardization so that we can move forward in the way we're using this data. But with that, I think it's really important that we don't lose the collection of more nuanced information because what we could potentially be losing at times is incredibly important to be acknowledging and addressing if we really want to improve quality of care and really reduce disparities in our communities.
Yes, thank you. So I would like to open it up for questions from the audience, so please put those in the chat if anyone has any questions. While folks are doing that, I did want to sort of pull together a few threads and then ask a question to the panel. So it sounds, I mean, a few of the things that have come to the fore here are the importance of standardization, while also making sure that the information that's being collected and the way it's being collected is nuanced, but also informed by a wide array of folks, basically everybody for whom these questions are important, or to whom these questions are asked. So what I also wanted to ask to this group is, if there's another state or organization that's going to start implementing a model or going down the same sort of path that you all have taken here, beyond those sorts of things, what would you suggest? What sort of advice would you give? And on the other side, are there anything you would suggest that folks take care to avoid? You know, it sounds like pulling a lot of community members together is really important, things like that. But what are some other things that might be helpful as folks take on some of these same efforts that you all are taking on?
I think one thing I might point out is, I know I've said it's really important that we start using the data, and I want to say use it with caution. I think we have to be really aware of what we have, where we're trying to go, and what we can do based on what we have available to us today. So using that data, but being really thoughtful and making sure that we are acknowledging the limitations when we're making that use, because one of the things we don't want to do is accidentally push ourselves backwards. We don't want to disincentivize our industry, our healthcare industry, from really being able to focus on this and better collect this information. So use, but with caution, I guess, is my message.
Yeah, I would offer the suggestion to whatever you're interested, whatever path you decide down is, make sure you're factoring in sustainability. Getting data and managing data and having data analysts do these things it's not cheap. Additionally, like we had mentioned, 5 to 10 years from now, we maybe not be using the same race and ethnicity categories. We're going to see some growth in that area about how people are choosing to identify. So also, sustainable, but also flexible in the approach. Don't make it too rigid on the front end. I would say those two are the two big ones for me. Oh, and then the last one, along with engaging community leaders and sort of gatekeepers for the communities and stakeholders, that don't try to reinvent the wheel. Rhode Island recognized early on that someone else is already collecting this data, and let's try to integrate the systems instead of reinventing the wheel. So I would just say do an inventory assessment, a survey on what who's doing what in the state, and how can you integrate those into your processes, because there's cost savings there, and there's also relationship building opportunities to get more involved and speak the same language and start this sort of ecosystem relationship that we have in Rhode Island. So yeah, first step is just asking questions and reaching out, and doing a bit of a survey of the environment.
Great, thank you. Mark, it looks like we have a question for you from one of the audience members.
Yes, thanks. So the way that name gets used in imputing race and ethnicity is the Census Bureau, I'll talk about surnames, but there's similar things in place for first names. Census Bureau puts out a publicly available list of every surname that was used 100 or more times in the latest decennial census. And there are about 150,000 such names. And for each name, they cross-tabulate how often the person with that surname reported having a given race and ethnicity. And so if your surname is Williams, there's, I think, a 47% chance that you'll self-report being Black. There's like a 30-something% chance you'll self-report being white, and so on. And so whatever your surname is, those 6 probabilities are entered and combined with other information that's out there to assign sort of updated probabilities that reflect information about your first name, your last name, the self-reported race, ethnicity of other people who live in the same census block group as you, and then in some models additional information as well. And the idea there is that you wouldn't want to make a decision or conclusion or about any one person about this, but the way these probabilities can be used is you can make collective inferences about a group. Somebody with a very high probability of self-reporting Black, if asked, gets a higher weight in a given analysis than somebody with a low probability, and somebody who's actually reported being Black, of course, gets the highest weight of all, probability of 1. There's also a question in here about making imputations about gender. I haven't been involved in that work myself, since most of the data sources that I'm used in have self-reported gender, but I do know there are approaches out there publicly available that attempt to make predictions based on first name in particular, and there are and also looking at the comments, I know that there have been approaches that have been used with claims data to try to make inferences about transgender status through procedures, for example. But I've been less involved in anything trying to. I've always only had the opportunity to work with self-reported gender and gender identity data myself.
All right. Thank you, Mark. Well, that brings us to time. Brings us to the end of our panel. I'd like to thank our panelists for all of their work and for taking the time to sit on this panel. I'd also like to thank Tanya Bernstein and Jen Toms for helping to organize the panel. And of course, I would really like to thank NATO for hosting this conversation, and to the audience for your patience and participation. So with that, Norm, I will pass it back to you.
Thank you, Jesse, and thank you to our panelists. This was fabulous and engaging. Just have a couple of things as we're closing out our conference. The first thing to let everybody know, all of the sessions have been recorded, and except with the exception of the one that we're still doing, all of those recordings are now available. So if you go back into the agenda, you can find the recordings. They're already there. They're ready to go. This one will be up there as soon as whatever time it takes to process, probably about an hour. And so make sure that if there's something that you missed or something you want to see again, go back and check it out. Secondly, Boston is going to be fun. I don't know how to sell it any more than that. It's going to be fun to be with people. It's going to be fun to be in Boston. We're going to have a great time all the way around. So we're excited about that one. Please put that on your calendar and put it in your budgets. We have a lot of people to thank. Let me run through this list. I want people to do individual name board, the program planning committee, all of our sponsors, all of NATO's strategic partners, all of the session organizers, all of the moderators, all of the presenters, all of the panelists, and everybody on Team NATO. It took a huge effort to pull something like this off, and I think everybody deserves a round of applause. I don't know how to do that in a virtual world, but we'll just do whatever we can to let everybody know that we appreciate them and their support for making this conference the great event. So with that, I'm going to officially close the NATO's 37th annual conference, and we will see you all in Boston next summer. Thank you, everyone.